The surgical standard in ICH care is quite varied in terms of there's no prospective randomized studies that have demonstrated unequivocally that it's effective. However, there have been case series that have demonstrated that patients who undergo evacuation of ICH spend less time in an ICU. They can get extubated more quickly. They end up leaving the acute setting of a hospital faster than those patients that don't. And so based on these less than prospective trials, there's been a tremendous amount of work being done in the neurosurgical space for evacuation of ICH, but focusing on technology that's navigation-based, that allows us to use navigation and then either use an exoscope or an endoscope to, under navigation, enter a pathway to the deepest part of the clot, and then perform an exoscopic or endoscopic evacuation. The developments that have occurred in evacuation has been focused on using navigation to guide either exoscopes or endoscopes to the deepest part of the clot. We call this using the long axis of the hemorrhage that allows us to get to clots that are deep in the brain and with a minimally invasive approach, evacuate those clots. As I mentioned, some of these are exoscopic or port-based, and the other large technology is endoscopic, where you really are using a camera to look through the clot and evacuate therein. There are clinical trials both in the exoscopic and endoscopic space. With the exoscopic trials, the most well-known is the ENRICH trial using Nico port in order to evacuate hematomas to demonstrate benefit in those patient populations. And there's a number of endoscopic trials that are going on right now to look at the endoscopic approach for evacuation. Again, not competing with exoscopic per se, but really looking at a minimally invasive approach to removing clot and gaining benefit from that.